This conference will now be recorded.
It's Tuesday, April 8th, 2025. Welcome to the AnCan virtual support meeting for high-risk, recurrent, and advanced prostate cancer. Thank you all for joining. I'm moderator Ben Nathanson, and I'm joined by moderators Lynn Sierra, John Antonucci, and Rick Davis, the founder of AnCan. You'll hear medical issues discussed, but we're just a bunch of guys. Nothing here is to be taken as medical advice. We thank these companies for helping fund these meetings: Bayer, Novartis, Johnson & Johnson, Myriad Genetics, Telix, and Blue Earth Diagnostics. As Johnson & Johnson heard this morning, we call them as we see them, nonetheless. Um, so this is great. I'm just scrolling down all the newbie questions. No newbies. So we go directly to you, Steve Rue.
Yeah, I think we do
Oh,
need to add foundation medicine as well.
oh,
That we
well,
forgot foundation. Not that they ever listened, but if they did, you know.
oh yeah, yeah.
No worries.
I thought okay, we'll talk about it later. Good. Thank you for letting me know. Foundation medicine. Thank you. Steve Rue?
Well, I don't know how I got first up on top of the list, but I've been listening the last few weeks with a lot of talk about the estrogen therapy, and you know, ins instead of I'm curious, and I'm going to talk to my doctor, and I got an appointment in 2 weeks. Talk to him about that, as opposed to doing the Orgovix. But then I started thinking more of, in eputamide, or uh, you know, taking something different than what I am now with the abiraterone. My thoughts started running towards the whole idea behind treating prostate cancer was, and I know we talked about, I've heard this talked about when they talk about taking a drug holiday. If you stay on them too long, you know, cancer can kind of get figured out how to get around it, or defeat the effects of the treatment. Um, and I don't know if some of you remember or not, but I started off with a year of Lupron, and and then I went to the Orgovyx and the abiraterone. And what I'm starting to wonder is having a year of each one of those. That should have confused any kind of cancer, adaptations. Um, but now I'm going to finish up a third year of the abiraterone and the Orgovyx, and I was contemplating the idea of asking my doctor about switching me over to darolutamide, uh, just to further confuse the shit out of these little bastard cancers, uh, in my third and last year of treatment. So I don't know. Am I like, uh, am I sounding insane, or is there any merit at all to that kind of train of thought, that line of thought? Just throwing that out there.
Why did you say my third and last year? I didn't understand what last year meant. Like, what do you
So
mean by that?
my first year of treatment was Lupron, only Lupron. And then because of you wonderful people here, I had a referral to Dr. Heath in Detroit, and she said you should be on a duplet therapy, and she got me on the Orgovyx and the abiraterone. Uh, so that's a switch with the ADTs right there. And going into the third year, thinking about, well, maybe I should do a uh, switch over to doing something different to further confuse these little bastard cancer cells by doing an estrogen therapy and doing a darolutamide.
Mm.
That would give
So,
me my third and last year of treatment, of chemical treatment, would be something yet again different. And I thought maybe there's benefit to that, or maybe not. I don't know. I'm sure.
Steve, let me just clarify for Jack and anybody else. I understand the confusion here. Steve Rue was is not recurrent. His disease hasn't come back. This was his diet. This was his initial treatment. Originally, he was Gleason 5+4. I don't know. Did you have any? Was there any lymph nodes or metastasis? I don't think so. I think he
Not
was
metastasis.
right. Right,
No.
just 5+4.
Well,
So
there was a when we originally took the history, there was a maybe on lymph
Yeah.
nodes. I don't know what
Yeah.
that means exactly.
Yeah. There was something in the report that said it, Jesus, what was the term they used? Indicated possible lymph node invasion or some shit like that. And I know for a fact there was vestibular, uh, 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 there was something involving the vesticulars as well that they said, yeah, it looks like something's there too. So
right, but a lot of guys in here they sometimes don't think of the fact that if you come in and you are high risk to begin with, then we can initially look at a defined period of treatment, usually somewhere between 18 months and 36 months. And that's why, Jack, Steve's talking about 3 years of treatment. We hope he'll never have to go on. We hope it'll be enough, like it was for me, for example. But that's where the definitive 3 years comes from. Does that help clarify?
And the three
sorry.
years are up in March of 26.
Yes, I've just started my third and last year of chemical castration.
So the question and the issue is, if anybody wants to take it on, Len's here and Dr. John and Ben. Um, what about, and we talked about this a few weeks ago. I'm trying to remember who it was that said, well, where does this come from? Where, you suggest switching and keeping the cancer off guard. It's something that we talk about quite a bit here, and our experience has been that you don't want to stay too long on a given treatment. Too long meaning usually probably upwards of 3 to 5 years on the same treatment. We anecdotally have seen several guys who looked like they were doing great on enzalutamide or an abiraterone, and then after 5 years, when they finally saw some movement, we couldn't find another drug that would help them. And I think it's I think it's fairly well accepted in the GU medical oncology community that that it's not a bad idea to switch. Switch can include taking a holiday. I mean, back in the day, you never took a holiday. I don't even think. I don't know. Dr. Shellhammer will tell us. I don't even think Snuffy put you on a holiday. I'm not sure, but I don't think Snuffy put you on holidays, but he might have done. But the idea, even with a holiday, is that it does keep the cancer off guard. I don't know who'd like to comment on that.
In this case, raising his hand, going to darolutamide is not going to cut your testosterone.
No.
You have to stay on Orgovix or something in order to keep testosterone down. And darolutamide it does enable you to have a higher testosterone and still work, but it can, from what Heartstart tells me, once you get over about 250, darolutamide isn't effective anymore once your testosterone gets over that. So it's not like you're going to get your testosterone down completely or back completely if you were to go to darolutamide. But I mean, waiting 3 or 4 years, as Rick says, is what they found works before you have neuroendocrine. It's after about 4 years that it happens. What, 5% was it?
How's the current PSA?
Undetectable.
Thank you.
And Sierra?
Yeah, thanks, Ben. So there are two basic schools of thought here. That one is that resistant cells are with you, particularly in high risk, right from the starting gate. Um, the other school of thought is that resistant cells emerge following treatment, where the cancer finds workarounds from the mechanism of action that's currently in place. I asked my own doctor, Dr. O, where he stood on this, and he said he was on the fence. So, and maybe a lot of doctors are, and maybe that's appropriate because, we just don't have evidence to state otherwise. But as Rick said, a holiday is another option, which you didn't mention. Darolutamide is an option too, because it's a new mechanism for you, receptor blocking. You never had a receptor blocker before. So those are things you can talk to your doctor about. I mean, now that you're how long have you been undetectable?
Oh, since I started the Lupron 2 years ago.
Oh,
I mean, the Lupron knocked it down pretty
yeah,
fast and hard. Of course, it knocked me down too, but
right. Well, I think it's a legitimate discussion to talk about taking a holiday.
Yeah, but Len, this isn't really a holiday because he's not recurrent. This is how much do you do up front? Do you do
yeah.
18 months up front? Do you do 24 months up front? Do you do 30 months up front? Do you do 36 months up front? And then at that point, you stop and hopefully you never go back on again. That's the hope. That's the hope. Now, if it recurred, then we'd be starting to talk about holidays. But this is this initial period of hormone therapy.
Right.
And how long do we do it for? And then, and it's the discussions we used to have frequently with guys like Jim Ward. How long are you going to stay on for that first time around? And they're all arguing for 12 months or 15 months. And we're saying, well, we really think, the numbers say it should be at least 18 or 24. And then we get in, you remember those negotiations we've had so many times with the gents in here. I mean, it's a different type of situation. How long to stay on for up front?
Steve's um, Steve's 2 year interval was actually started when he switched to Orgovix in March of 24.
Mm-hmm.
But he had already been non-detectable on ADT for at least a year before that.
Mm-hmm.
And 2 years, I mean, Rick and I did 27 months. Rarely we get somebody that does 36 months or something like that. But really, the 2 year mark is already reached. And that's why
Mm-hmm.
thinking about a change now doesn't seem premature.
No. It's on the table. Another option, if you want to sort of tune it up, is to go to monotherapy abiraterone, which we've had plenty of guys that have done. In other words, you stop doing the Orgovix now and still stay on the abiraterone for a period of time.
Mm.
Weren't you on Abby once?
No, not until I started Orgovix, March
Oh,
of
sorry.
24.
What are you on right now? I thought you were on Abby.
I'm on Orgovix and Abby right now.
Right, you're on
Yeah.
Orgovix and Abby. Yeah, that's what I
Right,
thought.
right.
So
Been
you could go to monotherapy Abby. Just stop the Orgovix.
So, Steve, let me answer what I think your question was, which is that I like the way you think. I like you thinking out of the box. I think the problem with all of these things is that they work the same way. They work by suppressing androgen receptor, even though they do it by different mechanisms. And what the cancer evolves around is that kind of suppression. Um, so that I personally don't think that changing these kinds of changes will have any effect on the evolution of your cancer. It's the idea is that you want to switch up different kinds of therapy, or, as people have been saying, stopping altogether. The idea being to um, let the hormone sensitive cells kind of regroup, rise up, then knock them down again. Um, in any case, I'm going into the weeds. I appreciate the thought, but I'm not sure that it will that kind of switching to estradiol will be the will will act the kind of way will act the way that you'd like it to.
So changing the mechanism isn't really
Yeah, they're all
it's
acting.
not right the same way. Yeah.
It is.
Okay.
That does raise an interesting point. You have not tried it this other way with an androgen receptor inhibitor like darolutamide. Um, so yeah, it might be worth a shot as long as you're going to be doing it anyway.
Dr. Paul, you were trying to get in earlier on.
Just a quick, great discussion. The initial therapy is better termed consolidation therapy when you have radiation plus 18. It used to be 36 months way back, the first trial that really showed that there was a benefit from adding androgen deprivation therapy to radiation. And then obviously the side effect profile had to be addressed, so it dropped to 24. And as you say now, 18 is fairly well agreed upon. But that you mentioned is the initial, we'll say, a compartment of therapy, and the stoppage then is to see for however long you may be disease free. It may be 3 years, 5 years, sometimes as long as you live. Now, the intermittent idea has two aspects. A physician in Canada, Dr. Burkowski, way back said that if you started, you might allow the cells to resensitize themselves to the therapy, and there may be some therapeutic benefit. But most folks go on intermittent therapy for quality of life issues. So it has been shown that there's no disadvantage most of the time to stopping to just kind of feel better for 12, 18, 24 months and then restart again. I mean, there is some animal data that there's always been a discussion about the G0 cells, or the cells that aren't multiplying too fast, happily keeping the bad guys suppressed. Because if you want to look at very, we'll say simplistically, there's just so much room and so much energy. And if the good guys, even though they're malignant, dominate the scene, that might be reasonable for as long as that works. But that's theoretical stuff that's been bandied about. But the idea of switching from one androgen deprivation therapy to another to kind of get a better outcome, not likely to occur, especially when you're talking about the ARIs and abiraterone and DARA and ENZA. I mean, there may be a 5% chance that you'll develop a better, have a temporary benefit, but very minimal. And that's why one of the clinical trials that have used, the control arm as the ARI that you didn't receive, having failed the one before versus something else, have been questioned as being legit, because you're really, while you're getting a alternative therapy that's approved, it's probably marginal and not a fair control arm in a randomized trial. Well, I've spoken enough. Let you guys continue.
Yeah.
Thank you very much, Dr. Paul. Jack?
Can I ask who just spoke? Because I haven't heard you speak before, and whoever you are, I'd like to know who you are because I was very impressed with what you just said.
Well,
Your name is not listed. Who are you?
I spent my life as a urologic oncologist treating prostate cancer and have dealt with it for 25 years.
Well, you certainly sounded that way, except there's no name associated with it, so I didn't know who was talking. So thank you for sharing. I was very
So,
Surely.
I can't put his name in.
Dr. Jack,
yes, sir.
I will introduce you. Dr. Jack Baruch, who's a former NIH psychiatrist, amongst other things. Please meet Dr. Paul Shellhammer, who, amongst other things, was president of the AUA at one point.
Yes, I heard you speak before, yes, the other night, but I didn't know you were speaking tonight because it wasn't listed. Thank you for coming again, Dr. Paul.
Surely. Glad
And
to be here.
I think the two of you are pretty much contemporaries. I think you're probably within 12 months in age.
86, August 12th.
Yeah, 85, June 1st. You got me beat by a year.
Pleasure. Thank you.
Yeah, next to Dr. Paul, the rest of us look like amateurs because we are.
Yeah, but you're amateurs with a lot of good thoughts, I'll say.
So, I'm just looking, and I will put it in the chat window as soon as I find it. But I read a terrific article today that had been sitting in my inbox for several days. That was in Medscape Today last week about how cancer metastasizes. But it was and I've written it up already, and it's going to go into the reminder next week. But I allude to Professor Ben Nathanson here because it's almost like something that comes out of his progressions. That's the style that it's written in. So it's really easy to read. It's fun to read. It's a really lovely article. You'll all see it in the reminder next week. But it makes you step back and think, oh my gosh, how can these cells be so damn clever? How they work, how do they work around? How do they know to do this, that, or the other? They're just a little cell. And yet, you can't get rid of these buggers because they're so smart. Anyway, I'll put the link in the chat window momentarily, but I just wanted to give you a heads up to watch out for that article coming up.
It's probably because they're teenagers. The cancer cells are teenagers.
Rick, I would say that they're not smart. It's like AI, it's like computers. They don't know what they're doing. They're just programmed to mutate. And they may be mutating every day, 10 times a day, and all of a sudden they finally hit on a mutation that happens to be a workaround. And it's probability and genetic mutations.
It's amazing, though, that Darwinian evolution took millennia, and the evolution in our bodies takes years or
Not
less.
fair.
Yeah.
So you're done and dusted, Steve? Okay.
Now he's thoroughly confused.
Yeah.
I'm glad we could help.
Thank you, everybody.
Tell us what Dr. Heath said after you have this discussion.
Yeah. Well, it's not Heath anymore. It's now her protege, Dr. Fadak. Yeah, it's well, because she got promoted. Chief. What Rick? What did she get promoted to? Chief.
She didn't get promoted. She got hired. She got a new job.
Yeah.
She's now she's the chief oncologist, period. Chief everything oncologist at Mayo Clinic in Rochester.
Yeah.
And I think I don't know if she's the head GU med onc or whether Sartor is the head GU med onc or whether they actually have a head GU med onc. I know I caught the two of them talking to each other at GU ASCO, and I told them that this wasn't the place to have a staff meeting. So, but they were deep in conversation about something. So,
What's the name of your new doc at
Dr.
Carmel?
Fadak, Dr. Fadak, Fedak.
Oh,
So
He's
we
quite a
we kind
guy.
of. Oh, sorry.
He's quite a guy. He's pretty sharp.
So we turn to our special correspondent, Marc Valens, just in. Hey, Mark, what's up?
Well, there must be people ahead of me that want to talk.
Oh no, we cleared a space just for you.
Well, I just had a talk with Dr. Aggarwal. He's my GU med on, and he's pretty happy with how the Pluvicto is going. And so we're just going to. I get a scan in a few weeks, and then I'll get my third Pluvicto, and can talk to you later, Rick, about. There's a couple reasons why he doesn't want me to think about estradiol, but basically he's happy with how things going, so I'm happy.
No, I was definitely going to ask you what his response was to estradiol, and I also wanted to ask you what his response was to the bone strengtheners and what he said to you about that. So take them in turn, either one, you choose.
He had reasons against both of those. There's not a lot of evidence of people on Pluvicto also on estradiol. And there's estradiol works fine for people who are not on Pluvicto, and some of them are on chemo and okay, but he was reluctant to go that direction without any evidence.
and what about the other question, the length of time being on denosumab?
So one of you guys suggested last time we brought this up that I go to once every 3 months instead of once every month, and he liked that. He said both with my whole history and on the Pluvicto that I still needed a bone strengthener, but cutting it down to 1/3 every 3 months should be just fine. But you got to taper off. You can't do it all at once.
Leonardo, what's you are now on our expert on the bone strengtheners.
Well, I already expressed my opinion last time, which was that there was a paper. It had to do with breast cancer, not prostate cancer. But, the ladies take denosumab also because they face the same issues when they're deprived of estrogen and we're deprived of testosterone.
Mm-hmm.
So the paper had demonstrated it was entitled "How to Safely Stop Denosumab," and the answer after clinical trials was that a single dose infusion of Zometa will lock in the gains that your bones have made being strengthened on Exgiva. And I can't remember their recommendation of when to stop the Exgiva, but something like 3, 4, 5 years, something like that. Of course, the longer you take it, the more likelihood or the increased probability that you will develop osteonecrosis of the jaw. So I had the Zometa infusion. By now, I think it's 2 years. And I recently had a bone density scan, and sure enough, it did hold the bone density readings that I had while I was taking Exgeva.
I had a
Were you on?
conversation with my dentist about this a few days ago, and she said that they they see much fewer cases of ONJ these days because it used to be that people would stay on bone strengtheners forever, and now they don't anymore. And that's why she doesn't see cases anymore.
Yeah.
So
I
Len,
think
Goes
were
right
you on?
along with what Len was saying.
Len, were you on Pluvicto?
No, never.
Okay, because Dr. Aggarwal, he he talked about Zometa, but he wants to get me through my 6 cycles of Pluvicto before he makes that change.
Okay.
Mm. But other than that, he was very happy with you. He was happy with your progress. And what's going on? I mean, I know you've never made that much PSA. But what do we know what your PSA is doing?
It's come all the way up to 0.05,
Mm.
but it's still hardly anything.
Mm.
Um, well, the one other thing he did bring up, so I get my next PSMA in a few weeks, but he also wants me to get diagnostic CT scans of the chest and pelvis to make sure that it's that whole concordance thing that there's not any
Right.
neuroendocrine coming somewhere. So he wants I should get both at the same time.
Right. Yeah. Yeah. Great. As you know, I like Dr. Rahul. I've always liked him. Known him for so many years now. I think he's a terrific doctor and just kind, compassionate, very smart. Um, he just was the lead author on a paper that I didn't understand. I think Ben might have been about the only one who did understand that paper that I sent around from Rahul last week, Ben. What was it in summary? We have time today, so we could remember. What was it that he was pointing out to us?
I actually don't remember.
It was a new treatment when enzalutamide failed, I think, and it was a phase
Oh,
one study. Remember?
oh. Yeah. Yes. This is CD46
Yes, CD46.
with the epitopes.
Yes, with the epitomes. Tell the guys in your simplified language what Dr. Rahul's studies about.
So this is actually sort of interesting, though. It's not near term, sadly. So PSMA we know has its drawbacks because it's not really prostate specific. There are other places in the body that express PSMA. Um, and also it's not too useful for neuroendocrine cancer. So CD46 this is an interesting story. It's expressed in a certain way in only prostate cells and placenta, which is not going to be a problem for us, only prostate cells, and it works equally well for um, regular prostate cancer and neuroendocrine prostate cancer. And the funny bit about this is that CD46, it's like PSMA. It's this transmembrane protein that sticks out of the cell. Um, but every cell, almost every cell in the body expresses CD46. So in itself, it's not a great marker. Um, what's crazy is that in prostate cancer, the CD46 has a particular shape that it only has in prostate cancer and placenta, and they can use that as a target, a very specific target. It has the potential to be the most specific target that we have, with potentially the fewest side effects and potentially the least confusion in reading scans. Um, so this was a phase 1 trial of this that was, I don't know, not overwhelmingly promising. Shows how stuff that looks great on paper may still have a few bugs to be ironed out.
Mm. And what was the CD46 was the target, and what was the payload in this?
So it was MMAE. It was a really toxic chemo drug that they can't. It's so toxic you can't administer it systemically. So it takes this hypertoxic payload, which works actually a lot like docetaxel does. It prevents cell duplication. It takes the payload right to the cell. I don't know why they did it that way. I don't know why they didn't use a radioisotope instead.
So, Mr. Valens, next time you happen to speak to Dr. Rahul, if you want to impress him, just tell him you were very impressed with his CD46 paper, and look at it and watch his face and see what he does. I think he'll smile.
Okay. And I did get a plug in how useful AnCan has been for my journey.
Well,
And he was glad to hear that.
Thank you.
So he plans to scan you in the middle of your Pluvicto therapy or after it's done?
After every 2 Pluvicto, wait a month and then do a scan.
And it's a PSMA PET scan. It's not a SPECT CT scan.
Well, he wants me to do both the PSMA and the diagnostic CT scans because there's a chance my cancer could morph into neuroendocrine, and by doing both of that, you should see that.
Yeah, very fortunately, and I think this is part of Rick's thinking. Yeah, he's an expert at both, so you're you're so in the right hands. And
he's just
let's
so,
say us. Oh yeah, tell me more.
Well, he's so pleasant. It's like I don't want to get off the call with him just because I love talking with him some more.
Yeah.
So he's a great doctor.
He's a lovely guy. He's really, really a super guy. So that's why we love sending patients, referring patients to. You got a hand up, Dan.
I know. Yes,
I
Dan.
do. I want to make a compliment. Mark, your color looks great. Your energy is much improved. It's just great to see your improvement.
Yeah.
Well, here's some news for me is big news. I went to the gym the last twice in this week for the first time in 5 months. I could never get up the energy to even walk more than a few blocks. And I was feeling enough better. I said, I'm going to give the gym a try. I put in 25 minutes and it kind of exhausted me for the rest of the day. But then 2 days later, I went back for 20 minutes more. So, and it feels good.
Oh, yeah.
We're so happy. That's great news.
And the sun's been out, so maybe I get a little color.
It's good to hear you making so much progress, Mark.
Do we have others who wanted time?
Yeah, we do, and we actually have
Okay.
some people. Yeah.
I wanted to ask Dr. Paul a question, but put me at the end.
Can I ask a question for those of you who have received Pluvicto or have had experience with it on the chats? The scans that are obtained after 2 and 4 and at the end, but mainly during the treatment, as Mark, you said you were having, has anybody had the experience of their treatment being changed dramatically by that? by seeing one progression and thereby stopping, or seeing such great resolution that you say, why continue if your scan beautifully becomes normal and your PSA drops to undetectable? Has anybody had any? I haven't read anything to that degree, but you guys have the experience.
Yeah.
Well, I actually I asked Dr. Aggarwal about that because it turns out I'm going to get the scan, and then my third Pluvicto is up before I get to talk to him again. And I was a little concerned, is there any reason that you might see something on the scan and you wouldn't want to continue? And he said it's highly unlikely, but he's actually will be able to look at the scan and call me up or make a change or something. But he says occasionally, if you see progression has gotten really bad and the Pluvicto didn't stop it, then you may want to find something else to do.
Mm-hmm.
Yeah. And we've seen that. I'm just pulling up my list of people that I can know that have done Pluvicto, and so I think that was the case with Marc V. He didn't respond after, I think, 2 or maybe 3 sessions, and so they took him off it. It was the case, I think, with Aaron Wertlieb. He didn't. We've seen, I'm trying to think who it was. Maybe I'll remember as I go down. We saw one guy who did so well after 4 scans that they didn't give him the last 2. They decided to hold off and keep them in reserve. I don't know, anybody remember who that was? But I definitely, I remember the case. I'd have to look and see. Might have been Keith Lawrence. But yes, without a doubt, we've seen people, Dr. Paul, whose treatment has been impacted by the interim scans.
Thanks.
Oh, actually, I can't remember where I saw it. I heard of a case where they didn't see progress after 3, but then it started to
Yes.
Work after the 4th one.
Jerry Deans. Jerry Deans. God rest his soul. He didn't get anything. He didn't get anything over but he had the weirdest disease even from the beginning. I think, Dr. Paul, you may remember Jerry Deans. He was also a snuffy patient, lived in Virginia, and was vice chair of us too at one point in time.
Yeah.
He was a wonderful guy.
Yeah. Name familiar.
And he had the weirdest disease. And he was like a 3+3, and then his disease came back, and it was in his lungs from very, very early on, from like 2004 or 5, and it would go away, and then it would come back to his lungs. He had the strangest history. And then when eventually he did do Pluvicto, I remember we got him in right under the wire when they were doing the testing, when they were doing the trial, right before they closed out the trial. And he didn't respond for 3 or 4 sessions, and then he did respond, but not for very long.
Dr. John, your hand is up.
Yeah, I was hoping to pull this up for you, but I can't find it. I have read recently that an argument that neither PSA nor PET scans nor radiographic recurrence, that there is really no clinical measurement that is really good at tracking how well people are doing at Pluvicto in the short run.
Yeah, I'll make a comment, and maybe you folks saw the lecture by Eugene Kwan at PCI, but he talked about his experience with 10,000 PSMA PET choline scans. And of course, he showed the odd ones, but patients who had a perfectly normal PSMA PET, who had a choline that looked very unhappy, and vice versa. Patients who had a PSA that went to undetectable, and then had a choline PET that had unhappy scans. So his point was, you'd like to say that there's some correlation between, as you mentioned, John, the biochemical and the radiographic imaging, depending upon what imaging you use. But there's a lot of mix-up in the assessment as time goes on.
Mm.
Dr. John, so this is as measured by overall survival, that none of those signals have any impact on the overall survival? That people who do well or poorly on those things have the same OS? Is that
that they are every one of them not adequate for the job of predicting in the short run. And whether the final outcome that I'm talking about is overall survival or not, I can't tell. But once I find this, I printed it out because I knew it was important. I will send it to you, Ben.
Great. I wait with bated breath. Thanks, John. Thanks for
I have too many piles.
When you pick up those pieces of paper, it's a little scary.
You never know what I'm going to find.
So we're actually on our scheduled caller number 2, who's John M.
First of all, thank you, everybody. It's a privilege to be on this call. I mean that. It's remarkable. So I don't have a lot I need to cover, but I'm going to give you a quick update on where I am. I was diagnosed December 27th, Gleason 8, 3 cores. Then I had a clear PSMA PET scan. It was all in the prostate. I decided to do triple therapy, 24 months of Orgovyx, high-dose brachytherapy boost, and 25 sessions of EBRT. And I'm 2 months into Orgovyx. After 3 weeks on Orgovyx, my testosterone dropped to 13, and my PSA dropped from 25 to 4.9. I'm very pleased to say Dr. Russell Smolowitz is my GU oncologist at U Chicago. He's very, very sharp. And so I am getting my brachytherapy. Smolowitz added abiraterone and prednisone to my Orgovyx. And so far, no side effects. And I've been on that for just over a week. My brachytherapy is on the 22nd. So I'm staring down that pretty quick. Here are my questions. Number 1, hot flashes have arrived. And they're mildly irritating, emphasis on the word irritating. And I'm looking for some strategies to manage that. Second, quick show of hands, how many people here have had brachytherapy as a primary treatment? Anybody?
Nobody.
Primary or part of their
part of a triple therapy, yeah. Anybody doing brachy? Okay, very good. So me too. So there was a rumor going around that if I get a prostatectomy, I only need 6 months of Orgovyx, but I'm down for 2 years. So hot flashes is a question. Has anybody gone through brachytherapy and can talk with me about post-surgical experience? And in my prep, I got a CT scan and showed a little bit of calcium in my cardiac area. And so I want a recommendation to a cardiac doc at Northwestern. It's not urgent, but they want me to get a consultation. So that's it. Any questions for me? Hot flashes.
Hot flashes. Well, who wants to lead off on hot flashes? We got 2 issues here: hot flashes and the cardio-oncologist. Who would like to? There's a lot of experience in hot flashes here. Who wants to dive in first?
Please tell me coffee will help.
Wake Jeff Marchi up.
Yeah, that's what I was thinking.
Oh, yes,
Bring
you're
Jeff
right.
Jeff is
Marchi's
sleeping.
wrists up.
Uh,
Oh, yes, you're right. Here he comes, Mr. Marchi. Hello.
He's awake.
He's awake.
Need you to talk about
You want to talk? You want to talk to John about hot flashes first? You want to kick off on hot flashes?
Hot flashes, anyone? Yes. Well, somebody in here said tofu works. You can do acupuncture. You can do the wave, which works okay. That helps really reduce the amount of the hot flash. They're sold by membrlabs.com.
What's it called? What is that called?
It's called the Wave 2. This particular one is, well, that's their mod. The current model is the Wave 2, WAVE 2. It's made by Ember Labs, EMBRLABS.
Okay.
.com, and it works great at night for this. If you get hot flashes when you're sleeping, it really regulates those. And like I said, I've heard a couple people say that eating tofu every day stops them. Black cohosh is another one of those treatments. Acupuncture, though, people have had acupuncture have said they've had to go back. One person said they didn't, but other people said they've had to go back regularly for it to work. And I got Depo-Provera when my hot flashes were really bad. My doctor had me get Depo-Provera shots every 3 months, and that's a hormone. There are similar hormones that you can take to it that can greatly reduce the hot flashes. Now, you on Abiraterone?
I know. Yes, I am. I just started.
You are. Okay. That one really brings them on.
Oh, thanks. That's great.
I found out, boy.
So, guys, if you're on abiraterone, there is a drug. Can you remember what it is? But it only works with abiraterone. And we've written it up. We have written it up. I'd have to dig in and see.
I don't recall.
Is it ringing a bell with anybody?
You're not talking prednisone, right?
No. The prednisone you have to take with it. But this is a drug that we've seen. It's repurposed. It's used for something else. And the study showed that if you take it with, it only works with abiraterone. It doesn't work with the Ide brothers. But are you? Ben's shaking his head like yes. So he vaguely remembers it. Anybody remember it?
Something like Viozi. Is that what you're thinking of?
No, that was a different. I think that was something different. Let me see. I'll try and look at it. But you've got a few people who want to speak up. And the Ember Wave. Len wrote a great piece on the Ember Wave in a reminder. Probably about 3 or 4 months ago, right, Len?
Yes.
I don't know if you can find it or if we have it.
I'll look for it.
And if you've got it, I can even forward the reminder on. But Len did write up a really good, and a lot of guys you guys don't, but most guys do get relief from it. But Ben, back to you, and I'll see if I can find this drug.
Jim Marshall?
Yes. The thing I would do is to have a fan blowing on the face, specifically on the face. I don't care if it was summer, fall, winter, spring, and that would help at night. I don't know if it would help you, but it's a cheap way to go.
Love it. Good.
I mean, I have this $300, Ember Wave, and I keep it on the charger. I just turn on the fan.
I do
Hey,
both.
make a deal. Go make it. Hey Ben, go sell it to John. You can recover something here.
When I have to go into like a play or the movies or something where I don't have the opportunity to turn on a big Lasco fan, I use it then.
Hold on, Ben. Does it work for you though?
Which one? The Ember Wave?
Yeah.
I put it in the better than nothing class, and uh, Jeff Markey has repeatedly stressed, you have to be really quick on the trigger. If you got to press the button as soon as you start to sense it coming on.
Okay.
Because if you wait too long, it will overpower you. It just chills your wrist. It's just a little refrigerator for the inside of your wrist. And sometimes it works magic, and sometimes it.
Okay. All right. Good. I got a bunch of ideas here. I want to talk to somebody about how quick will I recover from an HD brachytherapy boost? I'm getting it on the 22nd. I literally want to be working again the next day. But how long will I be down?
So some guys, I think, still want to talk about hot flashes. If you have capacity for David Opp.
Very good. Go for it. Tell me about
Yeah.
hot flashes.
I've been on long-term ADT 3 different times, and I've had good success with taking Effexor ER at 75 milligrams.
Mm-hmm.
That has worked well for me. There was one instance where after about 15 months, I developed night sweats, quite severe. And Effexor did not control them. So I went
I'm
with...
getting one right now.
Now, they're a nuisance on it, but I had wound up using an estradiol patch to get rid of the night sweats, which worked quite well until I developed gynecomastia.
Okay, that's a hard no for me.
Yeah, the estradiol patches especially, yeah. But the Effexor, it's an antidepressant, and I haven't noticed any side effects from it.
Okay, excellent. Thank you.
Rick, the drug you were mentioning, is it pregabalin, oxybutynin,
Yes.
venlafaxine?
Oxybutynin. Good job. That's it. Oxybutynin. And there's a very good job. And I think I've got the study. Thanks, Jeff. And it only worked, but it only works. It was a Mayo study.
I am, but I'm in this
And
Can I call you back?
can we mute Dan?
Yeah.
Can somebody mute? Thank you. It was a Mayo study that I think was presented last year at GU ASCO. And it was a small study of about 70 or 80 guys. And it was really effective if you, it was really effective if you were on abiraterone, but doesn't work for anything else. So check with Shmulowitz will know about it. Check with Shmulowitz, and I'll see if I can find the.
Can I get a spelling on that?
OXY. I'll put it in the chat
Thank
window.
you. Thank you. Excellent. Okay.
Thank you, David. Not heard of that. Courtney?
Well, I just wanted to say I had some pretty severe hot flashes when I was on Lupron for about a year. And I tried the Ember Wave and it really didn't work. But I forget the period, but they have a money back type guarantee. So I ended up being able to return it and get a full refund. And I also tried that black cohash or whatever you call it. And that was pretty useless.
Okay.
I was going to mention the oxybutynin. the primary purpose for that medication is for overactive bladders and for issues with bladder. So if you start to have those kinds of issues instead of a Flomax or something, that would be an option as well, because that would help with the hot flashes plus urination issues if they come along, you know. Um, but as far as hot flashes go, for me personally, when I stopped taking Lupron and then the second year started Orgovix, the hot flashes almost completely disappeared. I still have them occasionally. They're mild. I don't know if that's because I've lost weight and I'm doing more exercise and eating better, or if it's because I grew up in Texas and now I'm living in northern Michigan, so a hot flash isn't such a problem for me.
Thank you.
D?
You talking to me?
Yes,
Okay.
sir. Your turn.
My experience with the wave was that I thought it decreased the intensity and duration of hot flashes if you hit the button quickly, but mine failed. The back started just expanding. I think the battery expanded. I think somewhere in instructions it might have said something about don't overcharge it, but they don't give you any indication of when it's overcharging unless you're just watching it. My suspicion is that the battery just failed for overcharging. Just and what I learned from it though is chilling your wrist is helpful. So run cold water over your wrist. Doesn't work so well when you're in bed at night, but during the day and if you're out and about, it can work.
Cliff Collins?
Excellent.
Okay. I also tried the Amber Wave, and my wife loved it. I mean, it worked great for her. But David said something about Effexor. Effexor was also prescribed to me. I would use that as a last resort because it is hell to get off of. Once you're on it, it is one of the hardest drugs to withdraw from and get away from. So, at all costs, do not use Effexor unless you absolutely have to. A good old fan, like Jim says, just get a good old fan and work with it. I suffered through it, and nothing worked for me except just walking around with a little electric fan and put it on my face whenever the time came. But, oh yeah, one more thing works: exercise. If you work out, you will not have a hot flash. So work out a lot.
Doesn't work for me.
It's good for you. So hey, that's all.
Yeah.
So I'll comment on Cliff, a couple of Cliff's things. First of all, I did exercise every day when I was on hormone therapy. It didn't stop my hot flashes. And I was taking Effexor, but I was taking it for my mental health, and it didn't help me at all. Probably because my body was too used to it. So it doesn't work for all people. And just to circle back with exercise for John Maxwell, I was on the rowing machine the day after I had brachytherapy, but I had seeds. I didn't have a high dose, but I mean it was like fine. It didn't bother
Okay.
me, and I was exercising right away. So, but everybody's different.
Okay, that's encouraging. Thank you, Rick. All right. Wow,
Wait.
I didn't expect to get so much help on hot flashes. It's like I'm not the only one getting them, right?
This was like the slow clap. Initially, no one
Right.
responded, and then all of a sudden, 12 hands were raised. And Marshall, you want to jump back in?
One last thing, John. You said that you were just starting Abby for about 2 weeks. Is that true?
Yeah, even less than 2 weeks. Yeah.
Okay,
just started.
now make sure that for the first 3 months, every month you get the liver function test because the liver can revolt. I know mine after month 2, it said, oops, I don't like this drug. And so I was dropped down from 4 pills to 3 pills. And everything was okay. But just, you are probably getting it. I don't know. And also the thing I did was to get the testosterone test, okay, and a PSA essentially every month I was on it. And I still am. So.
Well, I'll be getting that test done this week, so I'm very interested to see how it turns out.
Okay.
Oh, that's a good reminder to take your blood pressure frequently also.
Drew?
John, what's your dosage of the Abbies? Are you taking 2 for an
No, I'm
empty
taking
stomach?
one.
Okay. And you do take the prednisone too with that, right?
I take 1 prednisone and 1 abiraterone with breakfast.
Okay. But the abiraterone, you're taking that on an empty stomach or on with a meal?
With a meal. Take them both with a meal, actually.
Yeah.
Okay. Okay. All right.
Yeah, that explains the single pill, Steve.
Right.
That's the
Right. That's what I was wondering. Yeah.
abiraterone protocol with food. It's much easier to take it that way too. But Dr. Shmulewitz is smart. We know that, so we'd expect him to prescribe it that way because it's much easier on the patient.
Okay.
I had to. Are you ready? Are we finished with hot flashes? Did you want to know about brachia?
Jack's hand
I'm
is up.
gonna.
Yeah. I just want to mention briefly, you mentioned VOs. I was eating, and I could hear through my hearing aid what you were saying. Veoza is for hot flashes. It's been approved, and it's expensive, and it directly works on the pituitary, and it's used with women. I don't know if it's ever been tested with men, but it is supposedly a strong and effective drug for hot flashes.
How do you spell that?
VEOZAH. VEOZAH.
Okay. Okay. All right. Good. All right.
Now, Steve, back to brachytherapy.
Brachytherapy. What's the first day or 2 after brachytherapy going to be like?
Theoretically, you could go back to work the first day. I mean, in my case, I mean, I'm not a lumberjack or anything, so I mean, it was okay for me to be a little bit active the next day. If you have a real physical job or something, may not be a good idea to do that. I didn't. My biggest issue was some urination issues, a little bit of blood in urine, and a little bit of a bowel movement problem. But that was all finished. That was all over with after the first day. 36 hours. I was feeling pretty good.
Okay. Makes it sound almost pleasant.
No, not at all.
Okay. Good. We're doing great here. We're doing great. Last question, not a prostate question, but if anybody knows any cardiac docs at Northwestern University, I'm looking to get a referral to a cardiac doc at Northwestern. Nothing in particular, but just a general overview of my cardiac situation. So if anybody has any recommendations, pass that along. But other than that, go ahead.
2 things on that issue. First of all, if you have any cardiac issues at all, that you should put them on the table with abiraterone, because abiraterone is more likely, in our experience, to have adverse events with people who have cardiac issues than don't. Secondly, I would be asking Dr. Shmulewitz if there is a cardio-oncologist at U of C that you can see. And if there isn't one at U of C, then is there one at Northwestern? I don't think we've come across anybody. Dr. John, have we come across anybody in Chicago, either at Northwestern or U of C, cardio-oncologists?
Oh, not that I can think of. But they're getting to be a lot more common out there.
Well, I don't have any lesions in the heart, but I want to get ahead of the game, if you know what I mean, right?
You just had some little bit of calcification in the
Yeah, I
coronary
had
arteries, picked up
calcification.
on an X-ray.
Yeah, that's what it was. So that's what I'm following up on. Okay, I will dig into that, and when I find a good one, I'll tell you guys.
Yeah, and I would start. I'd start with Dr. Shmulowitz and see if he can recommend a good cardio-oncologist.
Okay.
And then go from there, because there are issues. The drug interactions are important if you're looking at hard issues and you're going to be on Abby for a while.
Yeah.
Okay. I'm going to shoot. I think he knows I'm on it, but I'm going to shoot him a note. Shmulowitz a note. I'm meeting with him again on May 2nd, so I'll shoot him a note and let him know what about what I'm doing on the cardiology side. So I'm good.
Just ask. I mean, it's not so much let him know what you're doing. You want to ask him if there's a cardio-oncologist available, because they're not everywhere.
I will actually do that. Yep.
Yeah. Is there one? If there isn't, we can probably dig around for you at Northwestern. Well, he may know. He may be able to find out if there's a cardio-oncologist. Because if there isn't one, the only other place I would think of in the Chicago area where you're going to find a cardio-oncologist would be at Northwestern. Or you can just Google cardio-oncologist Northwestern or cardio-oncologist University of Chicago and see who you come up with.
Okay. Well, all of you have trained me. Don't just pick a name off a list. Get a recommendation. Know who the good ones are, right? So you've trained me. Thank you. I'm good. Ben, back to you.
Thank you, John. You got your money's worth tonight.
Right.
Jim?
Just an update and a quick update. I'm not going to be that. Okay. Quick review. Diagnosed 2017, stage 4 in June. Started on Lupron plus the abiraterone. Was on it 5 years. Been doing the holiday now since actually of June of 2022. So now it's going on 3 years. Testosterone started to recover about 9 months ago. PSA started about the same time. And so I've been tracking PSAs up to 0.08, and testosterone has gone from 300 to 400 to 500, and it's down to 300. And then I was reading something and I got a revelation. I was doing the math wrong. On the testosterone test, I was multiplying by 1,000. I'm supposed to be multiplying by 100. So my testosterone has never gone over 50. And now it's 33. So I went, maybe that explains the fact that for a year, my PSA is started at 0.03, and a year afterwards, it's 0.08. So could this be maybe a poor man's ADT treatment? Maybe. So I got a sneaking hunch that my testosterone was blown after 5 years and it's not going to recover. Is that a fair assumption?
There's a urologist in the room that might want to comment on that, but I would say that what's your age now?
80.
fair assumption. I also am on a poor man's ADT. It's been a couple of years since I've had a Lupron shot, and my T level is still down the toilet. I don't think it's going to recover. So I think there's a chance it might not. Paul, do you have a comment?
Yes, I agree. At 70 and above, after 2 years of ADT, very unusual for the testosterone to recover. I mean, it might be a lab error if it goes from 20 to 30, but that's the unfortunate situation.
Now an update on the heart, because because I was on Lupron plus the Abby, and so I read about Lupron bad for the heart, Abby bad for the heart, and so it's even worse. I had the echocardiogram, and my ejection factor is like, okay, 65, but I got a tricuspid valve that seems to be leaking. So eventually, at the time I go back on something, it will be interesting what Dr. Channing Paller will recommend. Although she poo-pooed Lupron instantly, so I know that that's off. So, but at this point, she says, come back at the time and where the PSA's 1. So as I said, from a year of 0.03 to 0.08, I'm hoping that it just doesn't skyrocket in a few months, but we'll see. That's it.
Thanks, Tim. Jeff Markey, your hand is up.
Yeah, I'm not so sure about this not coming back. I was on between Lupron and Orgovyx 8 years, and I quit about 6 months ago. And the second month after I quit, my testosterone went 83%. The third month it went up 72%. The next month 29.5%. And I've also heard from many people that their testicles have shrunk a lot, and that could be a factor in reduced testosterone, I would think. But mine never did. But I've heard from a number of people who said theirs did. And but I'm concerned with what's happened this month when after 6 months on it, off of it, how much it's going to go back up again this time. But there's no guarantee it's not going to go back up, for at least for me after 8 years. Just thought I'd give you a different point of view.
So what is the value of how much testosterone do you have? You talked about percentages up in.
Yeah, it's right now it's at 29. It started off at less than 5, then it went to 6, then 11, then 19, then 29 at each month. So it's been going up a fair amount each time, and the percentage of increase has decreased. Maybe it will slow a lot more, but I didn't expect it to even hit 29 after 8 years.
So the total testosterone is 29.
Yeah.
That's the max. What? You find that encouraging?
No, I don't. Well, I'm not looking to have it go back up. I don't want it to go back up.
Oh, I see. Okay.
Because if it does, I'm likely to BRCA2. I'm likely to be in trouble.
Hey, Marshall.
Yeah, anyway, I got a question. Okay, you think 29's good? I thought castration was about 200, right?
Right, but it's been going up at such a rapid rate every month.
Well, mine happened to jump from, 5 to 10 to 40. I mean, percentage, like 200% jump, 100% jump. But peaked at 50 and then dropped to 42 and it dropped to 33. But even if it got to 60,
I wouldn't worry.
is that a good
Yeah.
thing?
Oh yeah, no, I wouldn't worry unless it got over to about 220.
Right. So I figured, hey, my days are over with.
It's interesting to hear that yours went up a lot and then stopped. So hopefully the same will happen to me.
Didn't go up. It was a steady sort of climb, slow climb over a period of about 9 months, but I thought it was in the hundreds when it was actually in the teens.
Yeah.
And I was really going, wow, I got a 500 testosterone after 5 years? Why am I so special? And then I was a mathematics major in college, too.
So, Jim, actual castrated people, the castrate level is 20.
Okay, the castrate is 20?
Yeah, not 200.
Yeah,
We're
you
talking
got
about
that 100 factor in the wrong place again, Captain Jim.
So what is a normal testosterone? 80 or
Way
30
more
or
than
what?
3 years
my
ago,
normal.
mine was 400.
Yeah,
Yeah, right.
my
Okay.
normal was way up in the hundreds.
So what does a castration of 20 mean? You can do it or or
No,
you know
no. So
Might need a little help.
yeah.
It means you're castrate for sure. I mean,
Okay, but
15 to 20 to 25, it could be lab variation. Don't know if you send it to the same lab, but it used
okay.
to be that 50 was the accepted level.
Right.
But
Okay.
as tests got better and chemoluminescence was used rather than the old other methodologies, 20 is now what is felt to be the ideal number to have. But whether it's 25, 20, not much of a difference. And if it goes from 10 to 20, that's lab variation, not 100% jump.
Okay, but what is the advantage of you achieving castrate level? Like I should celebrate or
Yeah.
what?
Well, I mean,
Okay.
there have been studies that show when 50 was the approved level, that you could squeeze a bit more response, PSA wise
Okay.
and disease control wise, to driving it down even further. I mean, that's why the ARIs are so successful. I mean, they
Okay.
block, that's androgen annihilation, if
Right.
you want to use it that way. So
Right.
the
Sure.
less T around, the better
Right.
with regard to control.
Okay. Okay. Thank you. I'm
And
done.
when I was on Lupron,
hang on, Herb. We got a
yeah,
queue. One sec.
okay,
You'll be next. John
gotcha.
M., your hand is up.
Yeah, I'm. When I heard 2 years of ADT and testosterone does not come back. See, my ears still work, right? I'm on Orgovic, and they want me to be on 2 years. If I'm on 2 years of Orgovic, same rule. Lupron, Orgovic doesn't matter. It's gone.
What's your age?
I'm 65.
Oh, you're a young pup.
Yeah. Yeah, I think what you didn't hear, John, because we didn't really say it, is that this conversation changes as you get older. Now, everybody's different. Some people, the testosterone doesn't come back that quickly. Some guys, it does. Some of the older guys, it comes back very quickly, but they can't do math. It's really, it's by and large, and again, somebody like Dr. Paul can tell you, but by and large, for somebody who's a 65, if you're on for 2 years, you're probably going to be looking at somewhere a normal person. Nobody's actually normal, but it's going to take at least that amount of time for your testosterone to come back. But it should come back.
You say take that amount of time. It'll
2
take
years.
if I'm on it 2 years, it'll come back in 2 years. All right.
Yes, but it may come back quicker and it may come back slower. But it should be. At one point they would say it. There was an old heuristic rule, twice the time, but I think that's really too long. I mean, mine came back quicker. The other thing is that with Orgovix, again, it changes that rule, because Orgovix, we see testosterone coming back so much more quickly. So it's just anecdotally maybe 50%, even 75% quicker than the ADT drugs,
Okay.
the injectables. Sorry, the subcutaneous drugs.
Okay, so something to look forward to.
It also depends on your pre-treatment testosterone level. If you
Yes.
started out at 800, it's different than if you started out at 150.
Yeah, I was at 400 like 3 years ago. So.
Okay, did you not measure right before you started?
No, I got kind of rushed to get on the Orgovix, and so I didn't do a test right before it. But
okay,
so I'm at
we
13
always
today.
try to encourage our guys to get, because a lot of the docs don't like to do it, but we say insist, and you got to insist, and you got to measure. That's Captain Jim Marshall's standard line. He's the one who's always telling him to measure beforehand. He just forgets to tell them to check the difference between their 10 times and their 100 times table.
Right.
I'm not going to keep taking pot shots at him anymore. I'm done. Move on, Ben.
Herb, I'd like to hear from you.
Well, I was just going to say, when I was on Lupron, prior to Lupron, my testosterone was up around the 400-500 range. The Lupron knocked it down. At one point, it was virtually undetectable. And after I stopped Lupron and then was just on Nubeqa, within, I'm guessing, but certainly within 2 months, my testosterone was back up to over 300. But the crazy thing is, I didn't feel much different, other than the hot flashes went away, and of course my PSA was way down. But as far as any sexual advantage or anything like that from having a testosterone level of 400 to almost nothing and then back up to 300, didn't seem to make a whole lot of difference.
Thank you, Herb.
Well, Herb, that's because most of that testosterone is blocked at the receptors.
Yeah.
Okay, yeah. That would make sense.
I mean, if you were on Darrow, you said?
Yeah.
Yeah, so at least the way I look at it, that testosterone can get to your brain because darolutamide doesn't pass the barrier.
Yeah.
So
Yeah.
at least you have that benefit.
Yeah.
Yeah, testosterone serves functions other than the one it does in prostate cancer. So, yeah, you can definitely benefit by just having something to block the mechanism in prostate cancer. And it's the quote unquote non-canonical AR work is. Anyway, I'm saying too much. Len? Oh, you just spoke. Did you want to say something else?
No, I wasn't. That was different. What I'm here to do is confess to Jim Marshall. I had created a shrine in my home for you, an 80-year-old dude. After 5 years of Abby, his testosterone rose to 500. I'm going to dismantle that shrine. I'm sorry. Okay, that's it.
Gary Peters?
I am
my ADT and abiraterone, etc., had taken my PSA down to an undetectable level. And so I stopped all of that about a year ago. And I was told that my testosterone, given my age and the length of time I was on ADT, it's probably not going to come back at all. Well, a little, but it's not going to come back to any normal state. Well, it didn't budge for the first year, but now it has started to move and it's past the 50 level. Do I not want that to happen? Should I go back to an androgen blocker to get the testosterone under 50 or under 20?
Any thoughts?
What other drugs are you on?
What's that?
What drugs are you on right now? Are you on darolutamide or Abby or what?
Nothing, because I had been because I'd been undetectable for a while.
Yeah, get your PSA checked every 3 to 6 months.
Oh, I get it.
You're in remission.
But what I'm hearing is that maybe you're better off keeping your testosterone low and not taking the chance.
Gary, actually, mine was climbing like 33, 41, 51, and it peaked there and it dropped down to the 40s. Okay, and the last one I did was like 33. So there was a peak, and I get it done essentially every month. So I track that thing every month. So I don't know if yours will continue to rise. Maybe not. It could have.
Well, if
We'll
it does,
see in the next test.
if it doesn't, then the question answers itself. But what if it does? What if it keeps rising? Do I not want that to happen because of its possible effect on the quiet cancer?
Well, I could say
Hey,
what
hey, hang on. Hang on. Rick, your hand's up.
I'll defer to John and then I'll come in after John. Go ahead, John.
you're on a treatment holiday based on completing a course of anti-androgen therapy, and your PSA is negligible right now, as I understand it. The
Right.
The usual course of action is to use the PSA rising to a level of about 0.2 as the signal for when to go back on anti-androgen therapy, rather than using the testosterone level as a signal for when to go back on. So that would be the usual course of treatment for you right now.
Okay, thank you, John.
Rick, is that what you were going to say?
It was pretty much exactly what I knew you were going to say it better than me. I mean, I don't think, I mean, this is kind of, we can call it the Marchy approach, the Markey approach, you know, of managing your length of time on holidays through keeping your testosterone low. But that's not the point. The point of the holiday is to get your body back working as close to normal as you can. And then if you have to go on again, then you take the drug again. But if you're keeping yourself at close to castrate level all the time, you're not getting the benefit of being on the holiday. And who knows, you may not even, you may have a more permanent cure. you know, no, cure is the wrong word, but you may have a more durable, you may have a more permanent remission than trying to manage it through your testosterone. I wouldn't be, if it were me, I wouldn't be thinking about my testosterone, managing my testosterone. I'd want it to come back as quickly as I could.
Okay. And if it came back quickly, that's not necessarily a signal that the cancer's coming up quickly right behind it.
No, not necessarily. I mean, you know, that's what happens. I mean, yes, if we left ourselves on castrate level, we would probably manage it'd be another way to manage our prostate cancer. But we don't know whether it's going to come back. We don't know how hard it's been hit back in the first place from the original treatment. I mean, you are, as I recall, I don't have it in front of you, but you went on treatment with a second line anti-androgen for a while, and then you were on it for a good period of time, and then you decided to come off and see what happened. It wasn't an intermittent where it had come back and gone off. You're still in that phase where maybe we nailed it for you. And so why make ourselves miserable and when we don't know? Again, I mean, I go back to our philosophy here at AnCan is you got to live in the moment. And yes, if it goes up, then we'll worry about what we do next. That's what I would say, Dr. Jack.
Yeah, I just listening to this conversation, I'm thinking of my situation, 2.5 weeks on a holiday after almost 2 years on doublet therapy. And, my pre-treatment testosterone was 740. And, as old as I am. And, I'm thinking in the best of all possible worlds, I would like my testosterone to go up, not necessarily that high, but high enough so I can feel strong and, homeostatic on some level, that I'm feeling good again. And at the same time, hoping my PSA will not rise all that much and I get a real holiday. At the same time, I'm thinking I'm not sure I trust the PSA alone, and I'd like to follow it with either an FDG scan or if I don't reach the threshold of whatever, a PSMA threshold, scan, and or both, just to make sure that if I have a reoccurrence, I catch it early enough to get SBRT again, and go back on medication. So I didn't hear any mention of being followed with scans for your holiday, and I'm wondering why you're not even considering following getting scanned.
Because my doc won't order them.
Well, I mean, he won't. Is he planning on ordering it periodically from time to time, or?
He says we're going to wait for the PSA to start rising. There's no basis for a scan. I've had 2 doctors tell me the same thing.
Okay. Well, I hope that's the case and my PSA doesn't rise. But, I was told by somebody that you don't trust the PSA alone these days. You can you have a false sense of security and maybe at least an FDG scan to see whether or not there's anything growing, getting larger.
Yeah, I agree.
Good. Okay.
Does Belucich order them for you? You're muted, Jack.
If we talked about it enough, I'm sure he would, but I'm not at that stage because I'm only 2.5, weeks out, and I'm not at any point of having a conversation about ordering a scan. We've talked about it theoretically in the future that maybe, he would get a scan. He believes it's the PSA that we should follow and then act accordingly. But I don't know. The thing about the FDG, I've done some, reading and stuff, and I'm wondering about it. That's all.
Thanks.
Those reports have been due to people on ADT, on ARSIs that have the metastasis grow even though their PSA is low. It hasn't really been due to people who are off treatment having it come back without the PSA rising. Now, I imagine it could because some people aren't, maybe they don't stay PSA active and the PSA doesn't come up anymore. But it was really people that they were finding that people that were on treatment could get metastasis, and that's why they wanted to test them, because they could appear while under treatment.
Thank you.
You good, Gary? Okay. So we had 4 people who wanted to speak tonight, and now we're at number 4. Oh, Steve L.
Yes, if there's a minute for me to speak, I've got a quick something.
Oh, there is somebody ahead of you. That's the long-suffering Dan from Alexandria.
What I'm going to bring up here addresses some of the things that we were just talking about. So my PSA remains undetectable at 0.01 as of 2 days ago, but I continue to have pain in the hip and groin area. I've reported this before. The recent MRI that was requested indicated that it could be A, suspicious or highly suspicious for metastasis and maybe pathological, or B, insufficiency fracture. And my oncologist keeps agreeing with me it's probably an insufficiency fracture. But I have 2 questions. Since my PSA is undetectable, could the MRI be recording small cell neuroendocrine cell growth? And does anybody have any insights on that small cell neuroendocrine growth that might be malignant as a metastasis? And number 2, since we're just talking about the scans, I've done a lot of work on this recently. And is there any other scan technology that might provide a better evaluation of potential small cell neuroendocrine malignant growth? Both an Axemin and a PSMA will not detect anything that is undetectable, with PSA. It has to reach 0.2. And both an MRI and an FDG scan will record any inflammation. So if you have any other inflammation, it's going to report it. And you can't tell whether it's osteoporosis, arthritis, could be highly suspicious or not metastasis, but it's going to be making that reading, and it could be a false positive or it could be a real positive. So those are my 2 questions. I can repeat them again if people didn't understand.
No, let me, because I'm sort of keeping an eye on the time as well. I got it. First of all, the likelihood that this is neuroendocrine is very, very, very slim at this stage of your treatment. Now, it could have been neuroendocrine at the outset, although the incidence of neuroendocrine disease on diagnosis is less than 1%. It's really, really low. But if it was, it should have been seen on your biopsy. The pathologist should have seen and noted that you had that type of disease, but they didn't. So could you morph in a period of a few months? Very, very, very unlikely, unless you have exceptionally unusual and aggressive disease. So, we hear this stuff and then we think, oh, well, could this be me? Almost certainly no. Is there technology to see neuroendocrine disease? Yes, but it's not commercial yet. It's this DLL3 is a protein which is somewhat similar to PSMA, and we hope in time that it will allow us to identify either neuroendocrine or small cell like disease. Most of these guys that have this morphed type of disease, what they have is small cell like disease. It's not original small cell disease, original neuroendocrine disease. It's disease that's changed as a response to treatment. So I would say to you, number one, I would put it out of your head with the neuroendocrine if it were me. I don't think there's enough evidence. Number two, this type of technology that we're talking about, this type of scanning, it won't be available at Kaiser for years after it gets FDA approved. And if right now where we're sending people are to doctors like Dr. Aggarwal and Dr. Beltran at Dana-Farber, because they're running the trials. They're also running these trials at Memorial Sloan Kettering. But your profile, to me, I wouldn't be navigating you to be investigating that. I don't know. Anybody else have comments? Any other of the mods have comments on that?
I certainly agree that neuroendocrine is probably the least of your worries. Is it possible to get a bone doctor to make a differential diagnosis? And do you need to decide on this now?
Well, actually, my oncologist, looking at the bone scans and the CT scans, the historical record, as of 9 months ago, she's saying, no, it's not indicating that you have any metastasis in the bone areas.
And why don't you?
It's just the ADT, especially the prednisone, impacting and having the side effects. So that's the undecided question right now. And I agree with everything you just said, Rick. Thank you.
Gary Peters?
For what it's worth, Dan, I had insufficiency fractures that were quite painful for a while.
Insufficiently fractures in the hip or in other parts of the body?
Very low, like in the sacrum.
Mm-hmm. And what did you do? What did you do to treat it, or how did you address it?
Sometimes I laid on a heating pad. Most of the time I did nothing. And, I had a, I don't know what kind of, maybe an orthopedic, maybe a back specialist. I'm not sure who I went to, but they said they're insufficiency fractures. They may be painful, but they'll heal on their own. Try not to worry about them.
And when they read that, the radiologist, did they read it as insufficiently fractures, or did they read it as possible metastasis? Suspicious as metastasis.
They didn't say anything about possible metastasis, but they said probably insufficiency fractures.
All right, so it's a clear shot for you. Thanks.
Gary,
what kind of a doctor did that for you?
Well,
guy or what?
That's what I was just saying to Dan. This was around the time that I fractured a vertebrae from the ADT and prednisone. So I was seeing orthopedic doctors because of the fractured vertebrae. And I think it was one of those doctors who talked about the insufficiency fractures.
Did you have osteoporosis when you had the
Hey,
insufficiency?
guys, please use the hands function. Gal Shan has
Sorry,
been waiting
sorry, sorry,
patiently.
sorry.
Gal Shan.
Yeah, so I'd just like to ask a question based on a couple of things that were said today. As you know, late 2019, early 2020, I relapsed from my prostatectomy in 2013. And then I went on ADT and I did that for 27 and a half months. And I've now been off of that for 2 years and 5 months. And my most recent PSA test, it was 0.06. And I was advised that once I get to 0.1 to 0.2 is I should do a PSMA PET scan or a Plarify, depending what's available at OHSU in Oregon, and then determine what my treatment would be. Would that be correct, what I'm saying?
Any comments?
0.06 is the minimum of some of the machines out there.
No.
I know of people that have had that result and have gone to other places and have got it down even lower.
Right. But I was told, even though I'm at 0.06, I should wait to 0.1 to 0.2 or 0.15 before I would do a scan, based on the fact that I no longer have a prostate and had a recurrence.
That's what my doc says.
Okay.
That's you,
But
Marshall.
that's what the plan is with Channing Paller. I believe
Okay.
she said scans at that point, but she didn't say which scans. So
Right.
I'm assuming it's that one.
Right. Okay. Well, the only reason I asked the question is maybe the person still has a prostate, but they said tonight to one of us that you would go back on ADTs. But in my case, I was told that I should do the scan at 0.1 to 0.2 and then, based on the findings, decide what to do and where my PSA is at that time after the test. Okay, very good. Thank you.
Let me just respond to you right there.
Wait.
I
Dr. Jack has
know.
been waiting.
No, I know, but I don't, this is directly responded. I don't want people to think we are saying you go straight onto ADT.
Well, I didn't think so. That's
without
why
a PSMA.
I asked.
We have never, it's important. I'm sorry to jump in ahead of Jack, but it's really important. We never would say go back on treatment without doing the right scans.
Right.
So I don't know that you heard that right. Now, at what level to get that scan, whether it's at 0.0, 0.015, I don't think 0.1, that's too low. I think 0.15 has been discussed. I think the general consensus is a little bit higher. They'd rather see you get up to 0.2, maybe a little bit more. That famous Carol D'Amico paper that we've quoted suggested that you can miss it if you wait too long over 0.15, but there are some genitourinary medical oncologists who don't agree with that and are willing to wait a little bit longer. So but under no circumstances that we know of are we saying when you're in a recurrent situation after a radical prostatectomy to jump right in with
Right.
ADT without having done a scan.
Right. That's what I thought. That's why I wanted to ask. And the thing is, my PSA in December was also 0.06, and at the end of March it was also 0.06. So it stayed consistent.
So, I want to say to you guys, and I know it's difficult. I get it. I get it. This is anxiety. I mean, we don't want to call it anxiety, but it's anxiety. Um, and maybe Dr. John can say something about this, but when you guys are that low and then you're responding to small changes, and we've heard so many times in this group people getting so worried when it goes from zero point zero 0.06 to zero point 0.1. I mean, this is all within the margin of error. What we're looking at here is trends. We're looking at that trend, and it's what the guys in the active surveillance group say. Your trend is your friend. If the trend's heading in the right direction, stick with it. If it goes up one day, one month, and comes down the next month, that's not a trend anymore. Things can jump around, but if there's a trend, then we respond to it. And if that trend takes you up above 0.15, going to 0.2, then maybe we need to think about it. But that's the way that I look at this. I mean, Dr. John and Ben, I mean, this is it. This is really important stuff, because some of our guys at this low end, they can make themselves nuts over this stuff, and it's not healthy. It's not healthy, right,
Good
Dr. John?
point. Yep.
Dr. John?
Yeah. Yeah, you're right. Now, what happens if you're anxious about something and then you educate yourself about it, get reassurance from people? If your anxiety goes down, then that's great. If your anxiety still stays high, even after education, advice, and reassurance from people that know what they're doing, then you have to talk to somebody about it. Fair enough, Jack? Yep.
Right.
You had more you wanted to say, Jack?
I'm having all kinds of associations right now to what was just said, and which is different than what I initially wanted to say. I wanted to ask Gary whether or not he had osteoporosis when he had the insufficiency fractures or not.
I did not know it until I fractured the vertebrae, and then only then did they do a
DEXA scan.
yes, and said, "Oh, you have osteoporosis."
The other thing I wanted to say, which just came up, and I'll be very brief about it, is that I had a lot of anxiety when I had my reoccurrence in 2018, 2017, and showed up as detectable for the first time in 14, 15 years. And I was quite anxious about it. And I went on a tear to find out who had a scan. I ran to Quan accepted me because he was concerned I may have a de novo neuroendocrine, and he allowed to see me because I couldn't find any other scan other than a choline scan, which was the only thing available in 2017, 2018. So I went up to Mayo in Rochester, and then after he said, we couldn't find anything, after he did the scan, he showed me 100 scans, different scans with people with multi-metastatic all over the place, with PSAs of 0.11, 0.14, what my PSA was to justify the fact that he brought me up there to make sure I wasn't one of those. Scared the shit out of me, but I said, I'm glad I'm not one of those, but I always have remained preoccupied with the possibility of ending up one of those. And then I didn't end up, thank God, one of those, but I ended up, after 5 years, finding it in my lung and in my bones. And, my God, so when do you say worry or don't worry? You got to be proactive. You got to stay on top of it. And I was staying on top of it. And the anxiety generated a certain response in me that put me into action for years until I eventually found it. Without the anxiety, I may have gotten lethargic and, just said, let it be. I would have been calmer and more at peace. But I'm sure it hurts my immune system to get that proactive and that anxious and put me into action, and which is, not so good. but I didn't know how else to be because that's just who I am.
You can't win, Jack.
Yeah, I know.
You can't win.
Right.
You can't win. But there are pros and cons. But I think we try to sort of keep them within reason. I'm not going to go. I'm not going to go down the Quan rabbit hole. But
All right.
I don't. I think that as long as we're monitoring reasonably diligently, we're going to catch it before it goes too far in most instances. In your particular case, we couldn't find it anyway for years and bloody years. We kept looking and looking and we couldn't find it. And eventually, what was your PSA when they eventually saw something, Jack?
Yeah, when I went out to see Peter Carroll out there, my PSA when I went out to see him and I saw, the Japanese guy who did on the prostatic fuck.
Shinohara.
Shinohara. And I went out there with a PSA at the time, which was, it was about 0.3. 0.3.
Yeah.
And then I came back from San Francisco and it jumped up to 0.9.
Yeah.
And then shortly thereafter was up 1.2, 1.5. That's when Lucid.
I will say this to you. Jack. If you would have been in our group in 2017 or 2018, we probably could have gotten you in to get a PSMA scan at UCSF at that time. So we were getting people.
They were the only people
doing it in trial.
Yeah, I know. They were the only people that in UCLA at the time.
Yeah.
Were the only place. They didn't have it at Sloan.
Yeah.
And do we
How the heck have we managed to fill up 2.25 hours when there were only like 22 of us? This was a fantastic meeting. I don't think I've seen any. We had so few people who needed time, and we had so many questions, Ben. Right?
Steve L arrived a little late. He did have to get out of here at 8:15.
We have to be out of here at the latest at 8:20.
Well, can you make it?
Yeah. Well, based on a phone call of 3 hours ago, I'm starting radiation tomorrow. And I'm just either this week or next week, I'm just wondering what negative effects I might anticipate and how to avoid them, and perhaps what tests I should have during the treatments.
What kind of radiation?
Starting with 5 weeks of EBRT, followed by 5 weeks of CyberKnife boost.
Wow. 5 weeks.
5 weeks of CyberKnife?
CyberKnife?
5 days, you mean?
5 days, once a week.
Oh.
Oh. Okay.
So it's 5 weeks, once a week.
Okay, so we're debulking. We're debulking what are we doing? Debulking the prostate, Steve?
We're doing everything except the bones. There's nothing showing on the bones.
Okay. Well, I think, as you know, I have the incredible respect for Larry Fong, for Dr. Larry. He's right up there. He's really, I have to say, he's probably even ahead of Dr. Rahul. So, he's fantastic. And if that's what his decision is, I'd be trusting that. Hey, Mr. Valens, don't you be telling Rahul that I said that. But I think what you'd hear from Rahul is that he has the same sort of respect for Larry that I have. And what should you be doing? I mean, the advice that I always tell people, someone came in and said they were starting radiation this week. Try and get some exercise in every day. Try and, if nothing else, walk. Walk 20, 30 minutes. Gentle walking will do it. but it's really important. It's really, really important. And you might not notice for a while. Who else has done radiation and wants to comment on that? Who's done this type of radiation? I'm not talking about spot radiation.
Jeff, Doug D, did you want to talk about this?
As Jeff or for me?
Either one, either one. Did either one of you
Okay.
want to answer?
Since fatigue is probably going to be or is potentially a problem, protein, iron, make sure you don't short yourself on those things as well as having the exercise. Good chance you'll get a little bit anemic. Are you having ADT at the same time?
Yeah, continuing ADT,
Yeah.
Lupron and abiraterone.
I'm done.
Are you getting Spacor put in before you have the SBRT?
Discussed it, and no.
Right, because the results of SBRT are that after 10 to 12 years, you are going to have rectal and urinary problems, and it's pretty much commonplace. I was doing research about this yesterday, and it's a major problem with SBRT. Now, if you're having the SBRT done with the Meridian type, which is a tighter, I don't think that's being done at UCSF though. But it's the other thing are that I know for me, I had IMRT, which is the same as EBRT, and I had 7 weeks of it, and I had no side effects at all, absolutely nothing. I went to work every day right after, I had it first thing in the morning. I know other people that have had urinary problems, problems with diarrhea or other issues back there. The fatigue, as that was already mentioned. So it's all over the place. No two people are the same, like everything else in this damn disease.
I would refer you, Steve, to the next low intermediate group in 2 weeks. It's going to be on the 21st. Actually, sorry, it's a week today. A week today. Is that right? No, the 21st. It's on the 21st. And talk with Dr. Marc Perlow, who really knows a lot about IMRT, SBRT, PBRT, all these different things. Knows a lot about the gels. I'm not sure I necessarily agree with Jeff Marchi. The PACE-B trial, which have been looking at the last few days, seems to say that there aren't any long-term differences. This is a big trial that came out in the UK. At the same time, it gets really complicated because it has to do with the gating and how accurate these machines are. And as far as the the stuff they pump in, the gel. I would say the jury's still out. Some docs think it makes a big difference, other docs don't. My concern is that too often times it gets used because it's another way to bill. Especially not for you, but in a community practice. It's just that method. You talk to somebody like Mac Roach, he doesn't think it makes any difference. He didn't think it made any difference way back in the day. So I don't know. I'm not disagreeing with Jeff. I'm not agreeing with Jeff. It's very, very controversial. Last comment from Mark, and then we otherwise we're going to get multiple sclerosis people coming in the room.
No, I'm just going to say, like, Mac Roach does not do spacers, and I had mine 6 years ago. Similar radiation, except he does the CyberKnife first, and then the other, and I've had no problems.
All right, thank you much. Good night.
Good night, everybody. Thank you
Good
very
night, all.
much.
Good night. Good
Good night.
night.
Good night.
Thank you so much.